So my case is a pre-Impella case. How do I go backwards? Sorry. So what we have is a 76-year-old female with a, excuse me, he's a gentleman, with a history of bilateral femoral popliteal bypass surgery, end-stage renal disease, on hemodialysis, severe multivessel coronary disease. He's also got significant concomitant valvular heart disease with severe AS and severe mitral regurgitation, reduced EF at 25%, and was actually transferred to our center for a surgical evaluation for possible CABG, AVR, MVR. In the hospital, his troponins came up to around 5. His hemodynamics were borderline at points requiring intermittent vasopressor support. So what we actually opted to do here is after he was turned down for surgery, we evaluated him, did some CT scans, and decided to proceed with IVL facilitated access of the femoral arteries to treat his disease. So here's a baseline angiogram. And as you can see, there's significant diffuse calcific disease of the common femoral. And baseline coronary angiogram, you can see there's a heavily calcified distal left main with osteal stenoses of the circumflex and LAD, as well as a very focal calcific stenosis of the proximal right coronary artery. So baseline echo images, if you look here, you can see obviously he's got a pretty significant aortic stenosis. The EF is reduced at around 25 to 30%. He's also got a significant degree of MR. Again, there's another image of the valve, and you can see everything is just like a pile of rocks in this guy. Here's his baseline CT scan images. If you look, again, there's just diffuse calcific, almost concentric disease involving the iliofemoral segments all the way through and through bilaterally. He had significant disease, kind of similar to Tom's case, of the osteal subclavian axillary, and was just a diffuse vascular path. There were no options for transcaval access either. Again, you can see his groins are heavily scarred up, and so we usually use ultrasound, but sometimes you just don't need to. And this is our micropuncture needle attempting to get into the common femoral. You can see it bending around and the whole vessel kind of moving alongside with the needle. So what we did is we gained iliofemoral access, had a 6 French sheath in, and then basically treated the iliofemoral segments all the way up to the bifurcation of the iliac. And there's the balloon going up at low pressure atmosphere, inflations, you can see the balloon fully expands, and then afterwards this Impella CP sheath, which is 14 French, is able to be advanced with absolutely no resistance whatsoever. So from there, what we did is we used the single access technique through the CP sheath. We had a micropuncture stick beside the Impella catheter, and we subsequently upsized that, and we're able to do a concomitant balloon valvuloplasty with the Impella in place using a TCT balloon. And then proceeded to do a rotopro with a rotational atherectomy of the left main, and then did a DK crush of the left main LAD and circumflex. There's our rota. That's post-rota. And then our angiographic result on the left. And then while we were at it, we went ahead and fixed the right. So there's the initial angiogram. Of course, Shockwave's not approved for coronary use yet, so we had to use Wolverine balloons even after atherectomy. And you can see there's a little dissection which was non-flow limiting, so we left it alone. But overall, a good outcome. The more interesting part of this also is the ability to get through without having any residual dissections or issues. So what we did is we had a single perclose down with the Impella CP sheath. We then closed that perclose onto a 6 French sheath, did an angiogram to confirm that there was still good flow, and then used a Minx vascular closure device to stay extravascular. So overall, I mean, as someone that's known and really enjoys doing alternative access and has been really a big, strong proponent of axillary access, as Tom kind of alluded to, I think the rationale and reasoning behind and its necessity will probably diminish pretty significantly after this. So it was a great case, and the patient had a good outcome, and we'll come back for a stage TAVR in a couple weeks.